Daniel, camera roll. You want to stay here? Okay. Good morning, everyone. And I'd like to welcome you to this wonderful program today that we are commemorating the World Asthma Day. And today we will be talking about bridging the gap between knowledge and practice. All you need to know about asthma. And like I know that many of us, we are physicians, we are general practitioners, physiotherapists, pharmacists, and all the other allied health professionals. And I know that we have so many people from the public who are asthmatic or who are related to asthma patients or who want to know about asthma. Maybe you are also a press or members of the media or a religious organization or our partners all over the world. At whatever time zone you are joining us, we'd like to welcome you. And I want to say that you are in for a very good time. Today we gather to raise awareness about asthma, a chronic respiratory disease that affects millions of people worldwide. And this awareness is crucial in promoting early diagnosis, effective management, and improving quality of life for individuals living with asthma. Through education, support, and research, we can work together to reduce the burden of asthma. So today, this program aims to provide valuable insights into asthma management. In fact, all that you need to know about asthma. And I want you to sit back and relax. All of you that are online, we want to say welcome, and we love you, and we're happy that you are here. Please just make sure that if you have any comment or question, use the chat box, and our officials on the call here will also write out your questions so that your questions or your concerns can be attended to. So what I'm saying in essence is that if you have questions, please kindly use the chat box if you're online. And if you are also on site, you have questions, we'll be privileged to ask your question, or you can write to your question on a piece of paper and pass it to me or any of the officials. Without wasting our time, I would like to express gratitude to our speakers and organizers and all participants for their contribution to this program. This program is being hosted and is being anchored and organized by the Asthma and Chest Care Foundation. And this foundation has been involved in a lot of charity work, health talks, right from many years. So this year is going to be another year that you will benefit from the activities of this great foundation. As we go into the program, somebody will be talking to us about this foundation more. Please enjoy. So I want to, at this juncture, begin to recognize our hosts and our guests. Please permit me to recognize our host, the president and founder of the Asthma and Chest Care Foundation Nigeria, in person of Reverend Professor G. Erhabor. Please, let's put our hands together. I will invite you forward later. And I'm sure there are a lot of things to know about this great man. He's a professor of medicine at Obafemi Awolowo University and consultant chest physician at Obafemi Awolowo University Teaching Hospitals Complex. He is a fellow of the West African College of Physicians, the American College of Chest Physicians, and the Royal Colleges of Physicians, Edinburgh and in London. He's a respected pulmonologist and a global leader in respiratory medicine. Professor Erhabor has served in numerous national and international capacities, including as president of the Nigerian Thoracic Society. Can we put our hands together? Yes, he has also served as the vice chair and program secretary of the Chronic Lung Disease Division of the International Union Against Tuberculosis and Lung Disease, IUATLD, an executive member of the Council of Global Governors of the American College of Chest Physicians, and he has contributed to WHO policy documents and served. So many things we can say about this great man. He's also passionate about God, and he's a leadership mentor. He's written a lot of books, both in the secular and in the spiritual. He's written books on asthma, and I believe you will be able to benefit from his wealth of knowledge. He's more than qualified to organize this meeting. Please, let's put our hands together again for him once more. We also want to welcome one of our panelists online in person of Mrs. Folashade, who is Lawal. She's the CEO of Victory Pharmacy. Please, let's put our hands together for her. During the program, she will also be participating, and every other person online that we are not able to identify you now, but I'm sure as we go on, we will recognize you. You are all welcome and recognized. We also want to appreciate Dr. Abiono Oluwadamilola Odeyemi, the Senior Lecturer, Department of Medicine, Osun State University. You are welcome. And he also doubles as the Secretary General, Nigerian Thoracic Society. You are welcome, sir. We want to appreciate our professors, members of the respiratory unit, Obafemi Awolowo University. Let's put our hands together for them. We have Professor Awokpeju, and we have Dr. Feyi Kehinde, and many others that are joining us, all the other professionals. You are welcome. We have Dr. Kemi Taiwo, she's a pediatrician. We have Dr. Sharon Igbinoba, she's a pharmacist. Let's put our hands together. And all our press people and all of you that you are joining with us, we appreciate you. So this time, I would like to hand over to the president himself, our dear Professor G. Erhabor. Please, let's put our hands together as he comes to address us. Let's keep clapping. You can show love online. Show love.
Thank you so much for being here. We want to also thank Dr. Akinshoto here, who is in the languages and other aspects. So thank you for being in our midst. Today we are going to have a very short interactive section, and there are two key people who will be involved in the interactive section, but everybody will contribute both here and the other. One of the panelists is a professor of respiratory medicine. I also call her my professor of statistics because, and professor of pathophysiology, because she's so vast in things that has to do with mechanisms. She has had many fellowship awards, both from the US and from Nigeria, and she's currently the head of the respiratory unit of the National Postgraduate College. So I want to welcome Professor Aukpeju to have a seat, please. Another one I'm going to welcome to join in the panel is a consultant physician. She is very passionate. I used to call her ATS consultant. She's very passionate about research, and she's got awards from the ATS and also from the Liverpool School. She's a respiratory consultant and a fellow of the West African College of Physicians. She will also be involved in taking questions. Please welcome Fee. Now, you can sit here. What I'm doing here is just to moderate the questions and answers that will come. But before I go into that, I also want to welcome all our senior registrars, our recent consultant, Afolabi, there's a missed here. Thank you so much. And many other people are joining us online. Now, I will start by just giving us a short overview so that we can have the opportunity to get people to be familiar. I've been giving lectures about asthma now for over going to 30 years or so. So I will not be able to go into all the details, but I will sorry, there's a little age. Okay. Every year around the world, the asthma therapy is being reviewed by this global initiative on asthma, and they review the treatment and what is current. And every year, the first Tuesday of every month, people commemorate the World Asthma Day. And so the World Asthma Day actually is next Tuesday. But we decided to bring it now because of clash of events. And so the whole aim of this World Asthma Day, of which we as a unit has won awards. We've got awards severally for our organization of the World Asthma Day for several years, is to acquaint people with asthma. And our main objective is asthma is not a killer, as we say. It can vastly be managed, and attacks can vastly be prevented. And asthmatics, in fact, have a higher IQ than the other population. And they can also live a quality life. And so our goal is to bridge medicine as we know it with the community that are affected by the disease. And so for several years, we are advocating the fact that asthma doesn't have to kill you. And attacks from asthma can be vastly preventable. Now, one of the things we know about asthma is that asthma, let's welcome Reverend Ms. Erhabor. Yeah, she's also an asthma specialist on her own right, and she's deputy. So now, asthma is one of the common chronic diseases worldwide. And it's assumed that the prevalence varies from low prevalence to about as much as 18%. It's not being shown here. It's not all right. Now it affects over 300 million people, and it's assumed that by this year, over 400 million people would have asthma, and 500,000 people will be hospitalized because of asthma, and it's assumed to cause 400,000 deaths in a year. But as I told you, these deaths are vastly preventable. Now, it's assumed to be the third leading cause of preventable hospitalization. And they've said that it is a cause of presenteeism and absenteeism. What it means is that people get to work or get to school, but they're not able to do well because of asthma, or because of that they don't get to school. Looking at all the prevalence studies, I assume that over 15 million people in Nigeria could have asthma. And unfortunately, the large number of people are not diagnosed. And those who are diagnosed are not properly treated. Now, the cost of asthma is huge because of the rising economic situation in the world and because newer and more sophisticated drugs are being found. The way we treat asthma years ago has changed. We no more look at it as a disease of just that caused the airway constriction, but a disease that has some underlying mechanisms, which you call the endotype, and that will give more precision in treatment. Sorry. Now, when we talk about how much asthma is a burden of disease, there are many indices they used to measure them, but asthma is as bad as somebody who has schizophrenia or liver cirrhosis. And then it can lead to a lot of daily adjusted life years of over 21.55 million a year. Now, fortunately, globally, this prevalence is falling around the world. Death is falling, and also, but these are not the variability. It varies from one country to country and from nation to nation. And many of our countries do not have good documented facts. Now, what do we say is asthma? Now, because this is an education for the masses, not necessarily for physicians, when I graduated from medical school, we are all thinking of asthma as what they call a bronchospastic disease. A disease that leads to the constriction of your airways, and that leads you to produce what they call wheezes, chest tightness, and cough. But over the years, people now know that asthma is an inflammatory disease, which actually is the inflammation that produces the bronchospasm. But apart from that, we are now knowing that asthma is not just one disease, but a couple of diseases in one. And so it is heterogeneous. And then even within that heterogeneity, there are different subtypes. Now, I can tell you that the subtypes are several, and there are so many, depending on who is classifying it. But the truth about it is that asthma takes a variable course. We cannot say this is the point it will take. To some others, it disappears spontaneously. To some others, it must go through a quiescent period. And to some others, it may progress. Now, what we don't want to have is someone asthma becoming very progressive to lead to almost a permanent symptomatic state. Then we also know that asthma, they get irritable airway or twitchy airways, which we now call hyper-responsiveness. So when they are exposed to external stimuli, they tend to be hyper-responsive. That puts them in a bad state. The panelists will talk more about that later. Now, these are what I mentioned here. It's heterogeneous, it's hyper-responsive, and leads to the airway obstruction. Now, why do we have asthma? It's a combination of nature, which is the gene, and then people say early life environment, which switches them depending on what they are, either to a setting, promotes what they call a Th2 response. I won't go into details because we are not supposed to be speaking to the... Now, what are those at risk of asthma? There is the host factor, which is people who have atopy, and they show by having things like running nose, rhinitis, itchy eyes, conjunctivitis, sore throat, pharyngitis, eczematous rash. And then other things that are available. Now we are even thinking of obesity as a cause of asthma, and the panelists should be asked this question: how is this possible? Now, in the midst of this predisposition because of the genes, there is also the environment, which could be an indoor allergies or outdoor allergies. A thing like thunderstorm can lead to the breakage of spores that you can be healed. You know, things like danders from animals, you know, cats and so on, pungent odor, you know, even pregnancy, you know, even menstrual cycle. So some of these things could be idiosyncratic, some of them could also be universal. And then some of them could be occupational based. So there are very many things that can cause it. Now these are some of the things. This diagram was drawn by a physiotherapy student for about 30 years ago. And I think it's still, by that time we're using this, you drew these things, and they will now find pictures to represent it. The physiotherapy student is now in the US, you know. Host and environment meeting together will now give you the expression of the asthma symptoms, which usually cough, wheezing, which is that sound you hear, breathlessness, and chest tightness. Okay. Now, there are certain things that can have them to have increased asthma, and certain things that can make asthma decrease. We know that if you have a history of atopy, you are likely going to have asthma. And then, if during your early days or your early days of development, if, for example, you are used to have allergies, you are likely going to be protected from infections. That's what it is. But if you are used to having allergies, you will be protected from infections. In a sense, you'll be using antibiotics. And if you're having allergies right from childhood, you have sensitization. And so that's what they call the so-called hygiene hypothesis. And then those who are in families that do have infections a lot, and they are older siblings, they develop a different pathway of immunity. And so these people, they are likely going to have asthma. So we say that those in westernized culture, when there's some degree of use of antibiotics, they are most likely going to give you asthma with a Th2 response. And then if in much of the tropics, a Th1 response. But look, it is not universal, and they are changing thoughts on it. I'm not sure if the audience, are they seeing this? It's not here, nothing is here. All right. Now, there are several things I've written here, but these are lectures that will be given for, for postgraduate students. But you see, this summarizes everything you need to know about asthma, but in details. You have to have a host factor and environmental exposure. There have to be what we call pathobiology, which has to do with what we call the allergic Th2 response. Now, this also will now predispose them to the pathology we see, inflammation that leads to the narrowing of the airways. And then we see all the things that will happen. Then the pathophysiology is mainly, as I told you, inflammation and hyperresponsiveness and obstruction. And then the expression is variable airways and the clinical symptoms. Now, this thing, as simple as it is, each of them is a whole book. But it will at least, you understand that there has to be something that will give you the pathology, and that pathology will be expressed clinically by the patient having wheezing, cough, and chest tightness. Now, this is a schematic diagram that's things as old as going over 70 years or so. It was by one of these men, Professor Barnes, and I was lucky to have this thing given to me by his secretary in Imperial College. Now, what he was saying is that there has to be allergens who lead to like virus and pollutants who can lead to inflammation, then hyperresponsiveness, then there can be triggers, then you have the expression of asthma. Now, this again is over 70 or 80 years, 70 years, and it's from e-medicine. And all still saying the same thing, that asthma is a Th2 response with a lot of cells, bringing in a lot of mediators. Now, this is the most simplest expression of what I've been saying. Now, there are cells that are affected. I would say these cells are many. It could be mast cells, it could be eosinophils, it could be structural cells. They all produce what they call mediator soup, in which all of them are so many mediators. And then the effect of those mediators is the narrowing of the airways, mucosal edema, and so on. Now this is, I think it should be by now 80 years, and then it was the man who drew this did it several years ago before we started knowing anything about mechanism. Are we there? Okay, all right. So now for students, there's disease risk. You get it? Well, anything in medicine is now nature and nurture. Then disease induction. And I told you about C2 immune derivation. We give you cytokines. Then this is consolidated when this predisposition is there and there are exogenous irritants, which could be indoor, outdoor, idiosyncratic, universal, all kinds of things. It could be an irritant, it could be an inducer of all kinds. I know of a woman who says asthma is induced by palm oil. I know of a professor of pathology says by a nut. When he takes that nut, he knows it. Others, just perfume or coming to a place that is crowded. And that's why asthma is something you cannot say is not possible. Then you now produce all these things. What we don't want to do is that for those changes to come up so bad that the patient's asthma, this person's airway is remodeled, and so he continues to find it difficult to breathe in spite of treatment. All right. Now, this is a very complex thing, and I won't even go into that. But I just want to tell you that we are now thinking, we are changing the way we think about asthma, and that we are now looking at a lot of things that are involved, a lot of drivers that are involved. Th2 will release a lot of things. Alarmins, these alarmins are things that come from the epithelial cells. So when the players are involved, there is a lot of leukotrienes. They call it alarmin because alarming, and then you're usually upregulated on like than the downregulated one. But the end of it is that it produces bronchospasm. It's off again. Okay, all right. Okay, all right. Now, all right. Can we have it here? Can we have this on here, please? Okay, thank you. Now, I'm going to stop. This is going to be the last time for the. I'm not really giving you a teaching, just we are trying to mark time. Now, things have changed in medicine, especially for the medical students here and the young doctors. Initially, medicine was one treatment for all evidence-based disease, and medicine treatment was empirical. You have this asthma, one treatment. Then later, asthma became stratified into groups. You group them into a particular thing, or disease into group, and then you treat that group. You know what I mean? With a specific disease for that group. But now we now have personalized medicine. In that case, we look at individual treatment for each patient, and then it has to be evidence-based, and the patient itself has to be involved. It has to be a bidirectional thing. So now all of medicine is more or less of personalized medicine. Now, a simple thing I want to tell you is to introduce a thing called the phenotype and endotype. Now, you see, phenotype are the things you observe when you treat this patient, and it's usually an expression. The patient, you examine the patient, you do the lung function test. Those are the phenotype, what we see. Now, the endotype, is actually the mechanism underpinning the phenotype, and is shown by a lot of things like biochemical, physiological properties. So if you look at this, I can say that the phenotype, what can be observed and measured clinically, and I will show you something we use to measure asthma. But then when it now comes to endotype, they are the drivers, the pathological mechanism that gives us the phenotype. So in the past, we looked at medicine phenotypically. Asthma phenotypically is wheezing, is coughing, his lung function is like this, and we treat. Now we look at it now more with the endotype. And so that the endotype that is producing the phenotype is now used to treat them. And this is a massive work of evidence. Okay. Now, sorry. Okay, all right. Now, okay, all right. All right. This one, okay. I don't know why it's going back. Let's go back. I was going back. I hope somebody's not manipulating it there too. Okay, all right. Now, what I'm telling you is this, that when you talk of asthma, a lot of things, physiological allergies, comorbidities, and so on. Children have a different kind of asthma, adults have a different kind of asthma, and all those things must be taken cognizance of. Then, when we want to see the symptoms, look at the history, the physical examination, the symptoms, and then we do some investigations. And then we look at what precipitates the asthma and comorbidities. All right. Now, I will stop here. The management of asthma is very, very wild. And when we take the questions, we'll go into it. But we now think individual approach. You don't say this has asthma. Don't type the patient. Don't characterize the patient. You must have a fellow feeling for the patient. How you make the patient feel when it comes to you is more important than the treatment you give. And then you must empathize. Empathy is now part of the whole medical profession. So you must allow the patient to express itself. In many nations of the world now, they're not using lab coat, simply not to create a hierarchical approach. They want the physician to be like you. It's not like I'm descending on them, paternalistic dissension, but I'm working with you as a fellow person, trying to understand you, empathize with you, listen to you. That's very important. Then we also know that it's a step care approach. The drugs given depends on the severity and the other measurements that points to how serious you are. And then this step care approach also lead to an asthma management plan or asthma action plan, which people talk about. Then no matter what we do, we want to monitor the treatment. We monitor the progress of the treatment. We monitor it clinically, and we also monitor it physiologically to be sure the patient is responding. As simple as the peak flow meter is, I say it's as relevant to asthma as a sphygmomanometer is relevant to blood pressure. Then we want to make sure the disease diagnosis is correct, because there are several things that mimic asthma. Not all that wheezes is asthma. Then we want to use a holistic approach. Now the thinking now is to do what they call a self-management plan, so that the asthmatic knows what to do whenever he has an asthma. And when there's a severity, we look at it. Then, as I told you, you have to look at phenotypical, specific, targeted therapy. Then other things like immunotherapy is not commonly done in most part of the world. Then allergen avoidance. Some avoidance can be successful, but we don't know how far we are going to do it. Then we'll now talk about a non-pharmacological treatment. We welcome everyone. Welcome our dear friend Ugutola from Tribune. Yeah, she's one of our asthma, broadcaster for several years. And good to have him. And also welcome Dr. Joshua Okpeju, who is a CEO of one of the great establishments in Ife, and also a man of God. So welcome you, God bless you. Can we clap for everybody? Yes, thank you so much. Okay. Okay, all right. You can. All right. Okay. What's his name? What's her name? Tokola. We want to welcome the senior registrar from pediatrics, Bukola here. We also want to welcome the CMD of our hospital. Let's clap for him. He's online today. Clap for him. Clap for him more. I'm sure the higher your clap, the support. Give him one more clap. And I think at one point, Dr. Boyega will call him for comment. But I will start. We'll be doing it myself, and Dr. Boyega will be interviewing the people or talking to the people both online and here directly. I want to ask you, Professor Okpeju, since you have been managing asthma for several years, what has given you much concern about them? Yes.
Thank you very much, sir. And thank you so much for that refresher course.
Okay.
It was indeed refreshing.
Thank you.
Okay, I've been managing asthma patients for a few years, maybe like over 20 years. The most disturbing thing is that it looks like economics, it's people not being able to buy their inhaled drugs. The kind of prescription we give asthmatic is not usually what we ingest or injection, is usually what we call inhaled drugs. And that brings to mind that one of the caption for this year World Asthma Day is actually inhaled drugs for all. So for most of our asthmatic, there are usually traditionally two types of inhaler, one that will relieve the bronchospasm, and we have been told in this lecture that the most important thing is that soup of inflammation that causes the bronchospasm. So the paradigm now is that all asthmatic, irrespective of the level or how severe it is, should have what we call ICS for short, inhaled corticosteroid, whether regularly or occasionally. So, as I said, it is the purchasing power of people. There was a time, sometimes last year, like 2 years ago, that most of these inhaled drugs, they were not available. In fact, I was called by several of my patients that, are we not going to die now? Those are the people that are even buying it. In fact, there was a time I had to say that I'm not the president. I had to say something that this call were too much. There was a clinic day that I had like about 5 calls because the drugs were not available. So I think it's this looks like policy and advocacy, and that is one of the things we do at Asthma and Chest Care Foundation, is to appeal to our policymaker that this inhaled asthma drug should be made available to all. We have been told asthma is a long-term disease, a chronic disease. That's what it means. So and once it is treated or managed, asthmatic can live life without having asthma, or having asthma and not having the symptoms of asthma.
Thank you so much. Let's clap for her. Now, Dr. Feikende, how does a typical asthmatic present? How would we say that this person has asthma?
Thank you so much, sir, for that question. And I also want to join my professor to thank you for the wonderful lecture being given. We really appreciate it, sir. For a patient with asthma, the symptoms we say are often episodic and variable. What that means is that it's not often something that persists on a daily basis. They come up intermittently at interval. And there are cardinal symptoms that often characterize a patient that have asthma. We talk about cough, they can have chest tightness, they can have wheeze, they can have difficulty with breathing that we call dyspnea. And we must also know that these symptoms oftentimes are nocturnal predominant. That means they tend to occur more at night or very early hours of the morning. Just like Prof, you always say that if asthma is not nocturnal, it's not likely going to be asthma, so that you should also think about other things. I must also know that the symptoms, just like was said in the lecture, are sometimes variable. That means a patient with asthma can be fine now, in the next time they have their asthma symptom, and the pattern of presentation can also vary from time to time. So just to let us know that a patient with asthma have core symptoms that are called cough, chest tightness, wheeze, and difficulty with breathing. And then the presentation can come in different form. And we should also know that.
What's wheeze?
Wheeze are like noisy breathing. Sometimes we call it like a music. So you have this, like people who have asthma, they have this noisy breathing, which could be musical.
Does these symptoms just occur like that, or something brings it up?
Okay, sir, thank you. For patients who have asthma, they sometimes have what we call trigger factors. That means the things that incite or induce their asthma presentation. And this could be very variable. It could be range from environmental factor, which could exist both indoor and outdoors, that we call allergens. And sometimes it could be even host dependent. That means some genetic predisposition. So things like smoke, industrial pollutions, something like paints, allergens like pollens in the environment, and then even respiratory tract infections, viral infections. Then within the house, you can have house dust mites, cockroaches due to the proteins that they elaborate can trigger asthma symptoms. Then wet surfaces, if it's cold season, we can bring up some molds, can trigger asthma symptoms. Then people that smoke around them, these are sources of trigger factor. Then changes in weather too has also been shown to trigger asthma symptoms.
Now, Professor, someone comes to you, to us, and says that my mother has asthma, my grandmother has asthma, and I'm concerned that I would have asthma. Can you explain to us the role of genes as a causative factor of asthma?
Thank you very much, sir. I would leverage on your lecture, sir. Nature and nurture. But it is very important. Nature means the way you are made, your genes, your genetic compositions, all the DNAs, both the coding and non-coding one for people that have science among us. The whole genome now, that is, we don't really talk about specific gene now. We talk about the whole genomic component, the one that codes for protein and does not code for protein. Let me be a bit scientific, and there is also what we call epigenome, that even when the genes are made, the way it is configured, they all have causation in asthma. So for genes, the fact that my mother is asthmatic, my brother is asthmatic, does not necessarily translate that I would also be asthmatic, because there are other factors that comes into play. And the way asthma is inherited, in science we call it, it is not monogenetic or Mendelian fashion inheritance. That means once I have the gene, I will develop the disease, like people that have Down syndrome or what we call cystic fibrosis. And in asthma, there are several genes, over 100 of them has been discovered to affect our susceptibility. Let me put it that way. Genes increase your susceptibility to asthma. So over 100 genes. It's not just one single genes. The one that has to do with what we call beta blocker, the one that has to do with all the pathogenetic mechanism that our emeritus professor has mentioned. You know, all those interleukin, all those names, very funny names. What the protein that codes for them, whether you have them or you don't have them, increase the susceptibility to asthma. So having that background, if there are now other environmental things, and that environmental things can occur in utero. What I mean in utero, even when the baby is developing inside the womb, whether the mother smokes, whether the mother is exposed to air pollution, could also affect those genes and make asthma to come up later in life. Then the environment that we live in, we have been taught hygiene hypothesis that would diversify whether our immune system, our body soldier will be primed to fighting infection or to have allergic tendency. So in a nutshell, the fact that my mother is asthmatic and my or probably one of my siblings, that does not translate to me having asthma. But it could also translate that I have other disease that we call allergic tendency. I could sneeze a lot. I could be itching most of the time, allergic conjunctivitis. I could have some rashes on my knee, on my elbow. All those ones is pointing to the fact that there is a family tendency to have allergy. So it is possible to have the genes and not to have asthma.
Thank you so much. And also to further say what you say, that the allergies could be a spectrum of things, you know. In the family, you could have somebody have sinusitis, allergic rhinitis, that is nose, itching of the eyes, sore throat. I mean, not develop asthma, you know. But when you have those allergies, sometimes there could be prodrome that the asthma is going to come, and there could be also sign that you are allergically prone to asthma. And as you said, it can skip a whole generation. So it doesn't mean that it's vertically transmitted. It doesn't mean that if you are your mother have it, that you would also have it. But I will ask Faye one question. Then would I ask for there's a public commentator here who has been itching to ask a question. We'll call him later. Now I want to ask you a very simple question. Are there other associated diseases with asthma? What we call comorbidities.
Thank you, sir, for the question. Just like you rightly said before now, that sometimes asthma may not just occur as a single disease entity. It could occur in association with other spectrum of allergic disease composition, or with even other conditions that do not have to do with allergies. So a patient with asthma can have allergic rhinitis, so they have this running nose, they're having catarrh every now and then. Some of them can have what we call allergic conjunctivitis. So they have red eyes, itching eyes. You know, the eye colors can change brownish due to persistent itching. And they can also have some form of atopic changes, so atopic dermatitis, just like Prof rightly said. So you see skin changes. The other systemic conditions too, like what we call the gastroesophageal reflux disease, can occur in association with asthma. And for patients who have these comorbidities, it can worsen their asthma presentation, and control may be a challenge in this kind of patient. Then obesity too has almost been found to have association with asthma. And people are now advocating that people who have asthma and who have obesity, they try to lose weight in order to have a good control of their symptoms. The other, some form of other respiratory condition like what we call obstructive sleep apnea. Some can even have overlap with other form of chronic obstructive lung disease like what we call COPD. And then, so patient with asthma can present with other form of comorbidities.
Yeah, very importantly, there's a disease we call COPD, which is a chronic obstructive pulmonary disease. Now, this center has done a lot of work. I think one of the centers in Africa that has done any predominant work on COPD. But there's a big difference. COPD, unlike asthma, is not genetic. It's a disease that is environmental induced. Either they are smoking or there's indoor pollution. But as you say, asthma and COPD can overlap. Now we welcome Dr. Mafido. I nearly said professor because who knows where we get that. So he's a MD of Apex Group of Schools, public commentator, a politician, and a spiritual man. So can we have your question?
Thank you so much, sir, for this powerful opportunity. I have several questions, but I'll start with this. At what age can we say a child now has asthma? At what specific age can we say that, oh, this child
So you can write it and we can just
has asthma?
Just give us a question.
Then number two, I've discovered that asthma is environmental dependent. You will see that certain environments can actually bring out this disease. My fear is you've mentioned a wide spectrum of causative agents, and it is almost impossible not to have some of these causative agents. What is your advice? Because from the spectrum, both the rich and the poor can have some of these things. So what's the advice to further, mitigate it and then eradicate some of these things from our environment so that we can minimize asthma? Then the third question is, asthma as a disease, because it is not following the same trajectory like other disease. For example, some diseases are transferable from parents to offsprings. We have said now that asthma may skip a whole generation. And then we are looking at, it's also part of what the genes can transmit. So is it safe to say that asthma is in the world of its own because of the trend, the way it exhibits or portray itself? Now, we can't say it is transmitted from generation to generation purely. We can also say that it is not. So what category can you place asthma in that sense? And the last question for now will be, for now, what will you suggest that the government will do, to eradicate or, if possible, minimize the prevalence of asthma? What's your suggestion to the government?
Thank you so much. Now, Bukola will help us answer the question on what age, can you say clearly that a patient has asthma, and also tell us certain diseases that have asthmatic-like symptoms within that age group. Thank you very much.
Good morning, everyone. I'm glad to be here. So, talking about the definite age in which the diagnosis can be made in children is quite difficult and challenging. And the patients are individualized because according to what Prof said, there are a lot of childhood illness that mimics asthma, and the commonness of them is bronchiolitis. in which the patient can present with similar symptoms as asthma. They have cough, they will have difficulty in breathing, respiratory distress, and they may even wheeze. Viral pneumonia, which is the commonest cause of pneumonia in children, can also present with similar symptoms with asthma. However, with a lot of studies that has been done, especially in our departments in OAU-THC, we've been the earliest age that we have been able to make the physician diagnosed asthma is in a child that was 8 months old. And the most important history is history of recurrence of these symptoms. You don't expect bronchiolitis to be recurrent in a child. By the time a child is coming for this same complaint over and over, and there is a usual spontaneous resolution with administration of beta agonists, as early as 8 months, we have been able to make diagnosis of asthma in children.
Yeah, I think that's very unusual. Usually, in many cases, you will an 8 months child, can it take spirometry? You won't be able to do it.
No.
So we will not. We will, let's say at 8 months we want to watch, but I think it should be a bit earlier.
Earlier.
Yes. Thank you so much.
Yes.
Now, let's clap for her. Now we can take all the questions and straight to the point. The questions that he has asked, you can answer it. Answer the question here. If you don't understand the question,
We're talking about eradication of how that we mentioned about a lot of factors that can trigger asthma symptoms in the patient with asthma. How do we eradicate all this? Well, that may be a very difficult thing to do actually, but the teaching often is that asthma patients should try and avoid their triggers, which are individualized. A patient with asthma should know his or her trigger and try as much as possible. Some factors are modifiable. Take, for instance, a patient who knows he or she reacts to animal dandruff. Then don't keep pets.
What are animal dandruffs? Yes.
Thank you. So those are like falls that may be from dogs, from cats. So when those falls, they fall off, they can trigger some asthma symptoms. So if someone has identified that those are his or her triggers, then you avoid keeping pets. Then keeping of rocks at home that can generate and harbor dust, then you should try and do away with those ones. If you fry, you are going to respond, you are going to have trigger, then try and avoid frying. So it is as much as possible, look at those factors that are modifiable, avoid them. Those you do not have control over, well, to a large extent, I think like weather, you can't stop weather from changing, but just try and make some personal effort to protect yourself.
What of the role of preventative therapy in asthma?
Okay, sir. For patient, take for instance, I will cite this practical example. There are some patients that will tell you that if they want to exercise, they get their symptoms. If they be a child who is in secondary school, that you can't tell that child to stop participating in athletics. It's like cutting off that child from the rest. So for that kind of a child, you can have them have some preventive measures. Take, for instance, their inhaler. We've been told that their combination that has inhaled steroid with a bronchodilator prior to this onset of exercise, which will help minimize the symptoms to a very large extent without actually preventing that child from participating in that kind of effect.
Yeah, is there any question you want to take? Yeah.
Okay. Thank you very much, sir. I think I want to answer the question that what is the trajectory of asthma. It seems that it's different from most other diseases. The answer is that it is not. Most chronic disease, diabetes, most chronic disease have this combination of it's a gene susceptibility. It's not that the gene must cause it. So most chronic disease that I see, even some type of hypertension, not all kind of hypertension, there is a genetic tendency, and also there is an environmental component or lifestyle component. Let me put it that way. I say one day I will be a lifestyle coach. So lifestyle components also play important, and that is it with most chronic disease, hypertension, diabetes, some inflammatory disease. So asthma is no different. We now talk of multimorbidities that as you have heard that asthma can be associated with other chronic disease, obstructive sleep apnea, all those are things that, because we have some genes that make us susceptible, we also have what we do or in our environment that make us. So asthma is no different from, although the what is causing it may be different, but when it comes to the holistic management of most disease, drugs, lifestyle, and everything come to play. So it is not different. It may not be a purely inheritable disease, like when you have explained that earlier, maybe you are not in the house then. So it is not a purely inheritable disease, but hereditary has a play, and what we do and our environment also has a play, and that has been included in most chronic disease. Thank you.
Several years ago, I used to teach that know your asthma, study your own asthma. Then I think I also said that no matter how you study the things that stimulate your asthma, you can't leave the world. Because even if you try to prevent things within your environment, but you're going to go somewhere else. So we also say that mere trying to avoid triggers, while it's a good form of management, is not the main thrust of management. So the main thrust of management is to use a combination therapy that takes care, that acts both as a preventer and also as a reliever. And with that, you are able to prevent the disease. Now, why that is important is it's not so much the disease today, but the progression of the disease. Asthma is not like that kind of a disease, say, I had asthma attack and I'm cured. The underlying inflammation continues and may actually progress even when the patient is not having a visible attack. And that will invariably lead to the airway becoming damaged and the whole architecture of the airway disrupted. We don't want them to be like that. You see, let me give you a very true story. This happened somewhere. One of the leading professors in humanities had this asthma attack, and then he was being treated. And people say, well, he was doing well, he was doing well, he was doing well. And even the doctor treated him. He came to tell the doctor things are working well. But a few days later, they heard that he was sent to emergency and he died. Now, so in asthma, subjectivity is not objectivity. That is, subjectively, I feel I'm well. But there have to be objective measurement to be sure you are well. So even if the symptoms aren't there, the inflammatory situation continues. Then there's what they call sensitivity. Some people are not, in their perception, their sensitivity to their symptoms are very poor. You know what I mean? If you ask, how is your asthma? I say, I'm okay. But it's not really okay. So we do not base our this on subjective thing. There must be an underlying objectivity to see what is going on. So we always say asthma should not only be symptom-based, but also measure the response to treatment and also monitor the disease as it evolves. Because you don't want to get the chronic side, and you don't want to have a situation when the person has poor sensitivity to his asthma, and yet there's underlying chronic damage to the disease. The doctor there want to say something. This able secretary of the Nigerian Society, and he's Shubo, closer to the seat of government.
Thank you very much, Prof, for the very eloquent lecture. I must say that it was a really nice one. And I also congratulate the panelists too. Well, like you said, I'm the Secretary General of the Nigerian Thoracic Society. So in talking about what's the government doing as far as asthma is concerned, well, what I can say is that as a society, the Nigerian Thoracic Society, we're actually engaging the federal government especially through the Federal Ministry of Health. They have a non-communicable disease unit. Okay, so we as NTS actually represent the Nigerian Thoracic Society on the panel, and we're actually engaging them as regards making asthma medications actually available. Now, we know we have this healthcare insurance, okay? However, some of the needed medications are actually not covered by this insurance, okay? So what we're actually engaging them in is to make sure, of course, just as the theme of this year World Asthma Day is to make inhaled medications available to all. That's actually one of the things we're actually discussing with them to actually make these asthma medications covered by the health insurance years. And we believe that if that's actually covered, it will make the medications more readily available. Okay, so I believe that's one way that the government can really come in, because just as the panelists have said, yes, we've talked about avoiding triggers, but we have also been told here that you don't have control really over everything. I mean, even if you say you can control, so you leave your home, you actually go to work. You don't have control over those places. So government may not really be able to control them. Government can't control weather. Government can't control lightning. Okay, so but what they can do is actually to ensure that these medications are actually available to all by making sure that the health insurance can cover them. And as a society, Nigerian Tribes, we're engaging them in that regard. Thank you very much.
Thank you so much. Now, can we pass over to, let's clap for him.
Thank you very much, sir, for the enlightening panel discussion. Please, let's put our hands together again for them. You know, I see this as a very great opportunity for all of us to be a part of this move. You know, you can see that we are well seated, well accommodated in a very lovely environment. So let's give it to the host for hosting us in this beautiful place. And it's also to tell us that this is like a master class, but has been simplified for us, free of charge. Let's put our hands together. We thank you, sir, for all that you have been doing and all that you are still going to be doing, and the Lord continue to help you. We also congratulate all the team in the panel. We are looking forward to one of the panelists to also join. We are monitoring online. If she's available, she will also answer a few of the questions. But I realize that some people have questions in the house. If you have questions, please can you signify? And we also have people online who have sent in their questions. So I will be looking forward to Daniel. Can you please forward the question? So, okay, Olumide, you want to ask a question? Okay. Please, can you come? Yeah.
And then the medical students are here can ask
questions. Good morning, everyone, and thank you, sir, for the opportunity. While we mentioned that, I know very well that ventilator inhaler is very expensive, and considering the fact that we have quite a number of people that have this so-called disease, I believe there are drugs that can be used, because I know asthma is progressive in nature. The symptoms, it starts from maybe shortness of breath, and the person it's something that goes like from one particular degree, like to a particular stage where the person might not be able to breathe again. So I think there are drugs that can be used like prednisolone, salbutamol. Why don't we advocate those drugs to those people that are economically at disadvantage, instead of us pushing Ventolin, which can be very expensive, and you can probably when you get these symptoms, you can use this as a prevention kind of thing. That's it.
I would like to say a little bit on it, and if any of the panelists want to say, first of all, I want to, on behalf of this, thank Dr. Ademi, who also gave us some support for us to organize. Let's clap for him. And then we want to congratulate Akeju, I think, what's the name of the foundation? Breathe Easy Foundation in the UK, who have been sponsoring with peak flow meters, medications for asthma, and want to thank them for what they have been doing. Now, I want to say that what you mentioned is even the Ventolin, which is, we call it, what do you call it, a bronchodilator. The real name is salbutamol. We don't even encourage it to be used as a single disease. Many research have found out that it can even increase asthma because it doesn't deal with the hyper-responsiveness. In fact, it increases it. So the asthma therapy has changed over the years and it's very standardized. In fact, I will let one of the panelists just give us how we now treat them. And it's based off the experience over the years. Prednisolone is a tablet we don't use routinely for asthma. One, because it is a drug or a medication that gives a lot of side effects. So many side effects. Moreover, it's only used for acute asthma, and that's all. So we don't use it to lead to hypertension, can lead to ulcers, can lead to mood changes, can lead to skin changes severally. And the prednisolone is a tablet that goes systematically. The inhaler is important because it is localized. It goes to the airways. And a small amount of the inhaler goes to the airways, so few comes into the systemic circulation, so with little or no side effect. Little side effect. So we are, as much as possible, avoid a systemic drug which will give you a overt side effect, but do little to help the treatment. So why inhaler is preferred? Because it goes straight to the target organ. Small dose produce the maximum effect. It is simple, it is handy, and it can also be very useful when you need a rapid response. Unlike steroids, which you need as a long half-life, and it can only be used in an acute state, and also have a lot of side effects. Maybe if you can just tell us general principles of the drugs, use of the drugs you may not go to detail, just general principles.
Thank you, sir, for giving a very important prelude to the question. Just like Prof said, over the years, the treatment of asthma has undergone a lot of evolution. There's a body of scientific evidence that we call the GINA, Global Initiative for Asthma, that goes over the revision of how asthma should be managed on a yearly basis. The core principle, not to go into details now, the management of asthma is that we should have an agent that takes care of the background inflammation, which is what is called to the pathophysiology of asthma, and that is called inhaled corticosteroid. And this must be used in combination with a bronchodilator, and preferably a long-acting bronchodilator that we call LABA. So the principle now is that we use a combination therapy, what we call LABA-ICS combination, that is a long-acting beta-2 agonist in combination with an inhaled corticosteroid. And this LABA, the preferred one now is what we call formoterol. So you hear ICS formoterol. And the benefit is that in order to avoid patient carrying too many inhalers, you use one, you are having acute symptoms, you use one when you are having, just to maintain your and to enhance adherence. The formoterol is that it has the ability to act as a reliever because it has a short onset of action, and at the same time, it can work for a very long time. So it covers the patient for a very long time. So that is what is being used now, a single agent that is used both as a relieving therapy and then as a maintenance therapy. Maintenance therapy means when the patient does not have symptoms, for those who will need it based on which step they fall into. So they use it morning and evening. And then when they are having like an exacerbation, a flare-up in their symptoms, they also use this inhaler to relieve their symptoms. So just, it was like was said, there's no use of a bronchodilator alone as a single therapy for asthma.
Thank you so much. Over to you, Bwege.
Thank you. Let's put our hands together. Yes, we have some questions coming from our online audience. Have you sent it? Sorry. Yes, okay. Ogbuofia Stanley. He said, good morning, sir. You mentioned that breast milk can be a risk factor. Please, sir, I would like to know how can breast milk cause asthma?
Well, I don't want to. I don't want to answer it all right. Since she has been involved in breast milk, so.
Thank you very much for that question. We appreciate the question and your audience. Breast milk as and maybe I should start on this factor, on this note that when you say causative, maybe we should remove that word, causative. There are risk factors. Causative factor does not mean risk factor does not mean causative factor. So let's get it in any, when you listen to anything, cause, cause is a very strong word. So when we talk about asthma, we don't talk that it will cause this, breast milk will cause this. So what we are saying that it could be a risk factor for all the risk factors that has been mentioned. So remove the word causative like that. So what we are saying that there are several studies really that is for or against, pro or con. And for me, maybe I would say that I'm not sure it really causes asthma per se, but it reduces the incidence of wheezing illness. Then overall, I will still hand over to people that are specialists in breast milk. Overall, we won't say you won't give your baby breast milk because a research or 2 studies shows that it causes this. Actually, the best evidence is developed when you synthesize a lot of researches together, what we call systematic review or meta-analysis. So, breast milk taken as a whole, as just one singular thing, would not necessarily cause asthma or wheezing illness in children. But Dr. Bukola would shed more light on that. Thank you very much.
All right, okay, Bukola.
Thank you once again, Sama. For development of asthma in children, breast milk is actually a protective factor. The use of formula feeds in children, especially in the neonatal period, has been associated with development of allergy, milk allergy, and even asthma in patients with that have genetic susceptibility. So it's not a causative or a risk factor, rather is a protective factor for it.
What I agree with what brought this breast milk was the work that was done in New Zealand, and shown that work is like, I don't know if it was a real I don't want to call it. It was more of an epidemiological study, I think so, but it does not, as you said, mean it's causative, and doesn't mean you should not use it. You get it? So, but that study is there, and it has not been refuted. But it did not, that study did not say don't use breast milk, because breast milk has a lot of advantage. It's also protective. It's, you know what I mean, it takes care of everything. So that should not mean that don't give your child breast milk. But in patients that are predisposed to asthma genetically and so on, they must study their own response. Okay, more.
Yeah, thank you very much. Can we put our hands together? Yes, there's another question here. Thank you so much, Prof. and team. This is from Jarufu Momodu. I have some questions. Should biologics be introduced earlier in the treatment pathway? Should asthma be managed differently in obese patients? Can digital health tools, e.g. smart inhalers, apps, replace in-person follow-up?
Now, let me say that the first question and the third question, you answer it. Then obesity and asthma, you answer it. So start first.
Okay, yeah. Should biologics be introduced earlier in the treatment pathway.
Then the third one, okay, tell her the third question.
The third one is, can digital health tools, smart inhaler apps, replace in-person follow-up?
Okay.
Thank you very much.
The man who is
Doctor.
asking this question is a consultant in
Yeah,
respiratory.
in Abuja. So he's a doctor. So so my answer would so be a little scientific. So should biology, people here and audience, biologics are targeted, we call them targeted treatment. So as you have heard in this lecture, now we are typing disease, that asthma is now being typed depending on the mechanism that is causing the asthma. There are various mechanisms, when it comes to pathophysiology that causes asthma. So the question is, for the recommended thing, what is being recommended is that when we have asthma that is severe, that means asthma that has not responded to the drugs we have been talking about, or you need that drug at a very high dose, we say that asthma is severe. So the biologists, those drugs that we talk about, and anti-IL-5, IL-4, IL-13, don't mind all those IL, it means interleukin, don't mind what I'm saying. But what I'm trying to say, those drugs, they are very expensive. I'm not sure anybody has used it in Nigeria. It's possible that some people have prescribed it. But the question is, should it be introduced early? It is an ongoing debate. I know some group of researchers in UK are pushing that we don't want the asthma to be severe before we add the biologics. I know there is that line of thought. But as the debate goes on, and their line of argument is that, should we wait? And the drugs are now being tried, most of the clinical trials are on severe asthma, but now they are now being tried in mild to moderate asthma, depending on the level of drug you need to make that asthma to be controlled. So my own response is, my altruistic response to that, I think it should not be introduced early. Why I said that, from my practice, and I was asked a question, what is the most disturbing thing? Even the inhaled corticosteroid, that is the basic, you can't buy it. They have not been using it. We are trying to publish a paper, and the person reviewing it has to be on eosinophilic asthma or something, and he was trying to say that, what is their level? I said, in my country, he noticed that most of them are not on inhaled steroid. I say it is true that even when we prescribe it, they don't buy it. So my own personal opinion now, it's still opinion based. There is no science that suggests that we will use it in people that have less severe form of asthma. Let's start from the simplest thing. In my dialect, I will interpret in that when you want to use means pudding, you start from the lowest level. So please, let's make sure that instruction for what's supposed to go inside the lungs to go inside the lung. So technology will help. Then it comes to telemedicine. What is trying to say that will it replace in-hospital visits? Telemedicine means technology medicine where patients we don't have to come to clinic or I see them face to face, virtually. Yes, there are apps that's been developed that even on your phone, you don't even need any wearable devices. Even on your phone, that can tell me how control your asthma is. There are apps like that. All you need is to input, I cough today, I do this today. My peak flow, we have been told that's a measure of how our airway constricts. Once you can send that to me through the app, and I will see it and I will comment. During COVID, in fact, that gave the way to telemedicine.
Just to add to that, before you say a person's treatment is refractory, that is, it's not responding to other ones, and you want to go to biologics, which are just 10% of, so 90% of asthmatics can be treated, you must be sure the diagnosis is correct. You must also be sure that you have done what they call it differentials to be sure it's not others. 2, you must be sure the patient has optimized therapy for his level of asthma. Thirdly, you must be sure that the patient's adherence or inhaler technique is correct. Fourthly, you must be sure the patient has used steroids, oral steroids, and sometimes immunoglobulins. That's essential. And then sometimes also you must also be sure that there have been environmental control. So usually it's a disease of complete exclusion. And it's just that percentage of patients who are proved refractory to the conventional treatment, and it's less than 10%. And as you say, there are other factors that may be involved. So to just start a patient on it, moreover, these drugs are not devoid of side effect, apart from their costs. Then regarding technology, AI and such, like I would like to advise that when it comes to technologies, you always say, don't be too slow, don't be too fast. We know that there are cars now that can be driven without driver. And we know many accidents have occurred as a result. You know, when they started doing these, what they call it, that thing you put in the car, telling you move here, navigator. The navigator started directing the person, and when he came to the river, he said, "You are station." All right.
Thank you so much. Of the disease, and in terms of disease, in terms of the management approach, like we know, I will address it also because the person asking the question is also a doctor, so, and they also try to come to our level. Obesity, of course, there are some index measurements and things like that. Is some form of chronic inflammatory process that occurs, and most times the inflammatory process are systemic. So there are disease presentation. Oftentimes is believed that those who have asthma patients who are obese may come with severe asthma presentation. That means they find it difficult for their asthma to be controlled, even when they are using their drug as they should use it. Their inhaler technique is good, so the disease presentation will come with a severe pattern. That means you are finding it difficult to control that patient's asthma. And then in terms of the management of the condition, it could bring some challenges because in obesity you have some form of insulin resistance. Some have also shown that there could be some form of impairment with sensitivity with corticosteroid metabolism and things like that. So that means for patients who are obese and you are giving here corticosteroid, you may need higher doses to control their symptoms, for as compared with other patients who are not obese, whose level of asthma severity may be at the same level. I don't know if I'm passing the message the way it is in my mind. That means you take patient A and B. In terms of the inherent severity of the asthma, it may be the same. But if patient B is obese, for you to control their symptoms, you may need higher level of drug in terms of the inhaled corticosteroids to get the symptoms control because of the impairment in corticosteroid sensitivity in patient who are obese. So with that kind of patient, there may be some challenge with controlling their symptoms. Then in managing the patient who are asthmatic and obese, apart from dealing with the inhaled corticosteroids, you also have to deal with the comorbidity. You encourage them to lose weight, which is a very key thing in the management of patients who have obesity. And those who may have morbid obesity, some form of surgical intervention, which may be peculiar to the obesity, can help to improve their symptoms.
And it has been found out that if the patients lose weight, the asthma improved. And all the things I also mentioned, there's the mechanical aspect. When the patient is obese, it affects his, vital capacity, it affects his lung volume, and also that adds to the stress. And then leptin, which is usually regulated by the fat cells, is high. And in patients that have, obesity, they call it the hunger hormone. If you have too much of leptin, it triggers up that you don't need food again. If you have low leptin, it means that you need to take some more. And this leptin has also been implicated in patients that have obesity and also related to asthma, among many other mechanisms. Yes, over to you again.
Thank you so very much. I have a lot of questions.
also teach them inhaler techniques, how to use their inhalers properly, and debunk myths around inhalers. Some people medication precisely to where it's needed, and therefore they are able to use
Okay.
inhalers to achieve the desired effect, and that means
Okay. I think we lost that call. Can we put our hands together?
hello. Okay, I was heard. Thank you.
Yeah, thank you very much. Please, let's do it again. Let's appreciate her for joining the call. We appreciate your contribution. Before I continue with the question, there is a comment from a doctor from Oshogbo, and I'm going to read. This. Okay, let me read the question first. He said, thank you for this wonderful session on asthma. Where do you place a patient who has some symptoms suggestive of asthma, but spirometry is not conclusive? In fact, this patient was once admitted for acute severe asthma. What do one do as a physician? Thank you, sir, and Mass.
Question is, if somebody has symptoms that are suggestive of or has been admitted for acute severe asthma, and there's a test we call spirometry, that's a breathing test to know how much air you can blow out per time. That helps us to objectively document that the constriction is also variable, which you also need in diagnosis of asthma. So, considering my practice, the first thing to know that I would like to say is that not all that presents as acute severe asthma is asthma. There is what we call hyperventilation syndrome. People will just and they collapse. And when you examine them, actually, because the kind of the severity they present with, they will have nebulized them. Even without nebulization, you won't be able to pick what we also call wheeze in their chest. So it is not everything that presents like acute severe asthma is asthma. So many things. It could even be what we call a clot, acute pulmonary embolism. It could be hyperventilation. It could also be a cardiac, how will I put it? Acute myocardial infarction, a cardiac arrest or something. So it is not everything that presents. No, it is not. Having said that, it is also possible to have a patient with asthma that will also have a normal spirometry. So it is also possible that somebody has symptoms and signs consistent with asthma and also have what we call a normal spirometry. What you do as a physician or as a care provider in that thing is to be able to demonstrate that this airway obstruction is also variable. So what you do is, that is, I'm talking to healthcare professional now. So as much as possible, before you start your patients on this inhaled corticosteroid, try to establish the diagnosis objectively. and see if you can also be able to demonstrate variability. There are other ways that will be able to demonstrate variability beyond the scope of this lecture, metacolin test and things like that. You can also do, this is also linking scientific, we can also do what we call fraction of acyl nitric oxide, what we call in our terms phenol. You know, that is just measure a metabolic product from all the inflammation that occurs in the airway. You tell them to blow to a thing and we call it nitric oxide. Those are complicated things. But as much as possible, if treatment has not been started, you should be able to demonstrate that the airflow is variable. So if you have an asthmatic patient, the symptoms are consistent, you have excluded other cause, and the spirometry is normal. You can start the patient on the treatment, but you have to monitor the spirometry over time and see whether it is variable. So, but the key lesson is that before you start inhale corticosteroid, try and establish that these patients really have asthma. There are so many mimics of asthma, and not everything that wheezes is actually asthma. Thank you.
Thank you so much, Ma, for that wonderful response. I will address briefly some of the questions that we have here. Say, what advice can be given to those who, for some reasons, abandon the course of their medications for herbal remedies? Well, it's just like every other. What I think in this case is to just educate that patient, because asthma education is now very key in the management of asthma. So let that person know what asthma is all about, and let the person know the options that are available to managing asthma, and to let the person know that herbal remedies, as far as science is concerned, does not have a place in the management of asthma. And then you hope for the best. You can't force patients to take their medications. So, but you just keep encouraging, let them know what the disease is all about, and then the implication of not using their medications. Then said, it was mentioned that asthma only occurs at night. Why is it that? We do not say it is only, but most times it has a nocturnal predominance in terms of the symptoms. That is, these symptoms are more at night or early hours of the morning. Well, some theories have been put in place. Some say the reason may not be known, but it's believed that at night, some people get exposed more to their allergens. Take, for instance, somebody who has rugs in the room and reacts to dust. And there's been believed that during the evening period, the air becomes more humid and then drier. So when people are exposed to a more humid and dry air, it can sometimes cause some irritation within the airway, which can trigger out some form of bronchospasm that can also worsen the asthma presentation. Then the third question, I think Prof has addressed, I say spirometry, suggests restrictive disease. How do you manage the patient? Well, you first have to establish that the spirometry has been well done, because spirometry is a very technical thing. 2 days ago, or was it yesterday in the clinic, Prof was just saying that for you, spirometry is not just like any other technique that you do. You really have to know how to do it to be able to explain to your patient. But if at the end of the day, you already know this is well done and it shows restrictive pattern, then you have to evaluate along that line, which there are some other tests you have to do to establish the diagnosis.
Yeah, let's have the next question answered. Then after that, Dr. Afolabi will demonstrate the peak flow for us as a fresh consultant.
Thank you very much. I think most of other question borders on how we treat asthma. So this one says, does the use of Montelukast tablets come in asthma prophylaxis? Okay. Yes. Montelukast is anti-leukotrienes. When we are talking about that inflammatory soup, when Prof was presenting, you know, he showed one band slide. It goes from this place to this place. So leukotriene is one of the effectors that it would make the airway to constrict. You know, it is not a cytokine, but it's byproduct of what the cytokine does. So leukotrienes, that's the name, the mediator, that is what it's called. It will make the airway constrict. So anti-leukotriene is drug that acts against leukotrienes. And that is an example of that is what is called Montelukast. When it comes to, I'm not 100% conversant when it comes to children. But when it comes to the recommended guideline, we have been told about Guinea. The track 1 is that's the recommended one, the inhaled corticosteroid track. You know, there are other kind of controllers. So anti-leukotriene is a form of controller that will control the inflammation. Peradventure, there are other reasons, but let's get it that the first line and the most preferred, the most effective is inhaled corticosteroid. That is the corticosteroid we take through inhalation. So the tablet, Montelukast comes in tablets. What is the name? Multigent. They ask me, Multigent, all this. So I know people may prefer to use tablets. And that is the first line. But if it is associated with other allergic tendency, like allergic rhinitis, when you are always sneezing and things like that, Montelukast may also be prescribed with it, especially by the ENT surgeon. But the first line is inhaled corticosteroid. Then there is also a question that will it be used as prophylaxis? Yes, the first line is still inhaled corticosteroid. We've talked about prophylaxis when you want to do exercise. You can also take Montelukast pre-exercise or pre-exposure to pollen, but that is not the first line. And it is readily available in Nigeria. There is a question that says, is it available? Yeah, it is very available. I'm sure if you go to all these, everywhere, in fact, once you go to, they will just say, but that is not the first line of treatment, but it can be used. Then there is another question that says, Dr. Koinde earlier mentioned formoterol. Does that mean Seretide containing salmeterol is no longer a good choice? Maybe I will throw the question back to you, Ma.
Thank you. No, it's still the same thing. Okay, thank you, Ma, for that question. Well, why I'm not promoting any drug company, or we are not promoting any drug company as a team, like I mentioned earlier on, that we have a body of evidence that guides what we do that we call GINA. So they have 2 tracks. We call the track 1 and the track 2. And that has to do with the preferred and the alternative, which is what happens in most disease entities. We are not saying that salmeterol containing should be thrown into the trash. In fact, for some of our patients who have been on salmeterol containing, we do not change them if they are comfortable with what they use. But when they come to the clinic, we lay it bare, this is what is preferred, which is the long, so that it reduces the burden of carrying so many inhalers. Because those who are going to use the salmeterol containing, they still need a SABA, which is they will use as their reliever. But for those who use the alternative, which we call the MAT therapy, the maintenance and relievers therapy, or some call it SMART, single maintenance and relievers therapy, they feel is better in terms of adherence. But if your patient have been on salmeterol and they are doing well on it, there's no need changing them.
Thank you very much, Prof. I'm going to be talking about peak flow meter. Peak flow meter is an important tool in the monitoring of asthma. And it is advisable that every patient with bronchial asthma should have this tool. And the tool can be used to monitor their airway. We usually advise them to measure it in the morning and as well in the evening time. And they should measure it at a specific time. If they are going to be doing the test, they should do it maybe like 8 in the morning and 8 in the evening. And how is this instrument used? The instrument has a mouthpiece and a meter. This, we can all say, this red cursor is a meter. There is a meter there. So every patient, we advise a patient with bronchial asthma, whenever they want to do it, to sit or to stand. And they should not occlude the mouthpiece with their tongue. So they sit upright or stand, and they should blow as hard as they can and as fast as they can as well. So before they do the test, the cursor should be turned to 0. So when they blow through this, the Kusol will read, and they should take the reading in the morning, they should take the reading in the evening. And how can one know that they have a good control or they have a poor control? They should take the reading when the reading is between 80 to 100% of their best. They are in the green zone. And what green zone means is that they have a good control of their asthma. But if it is less than that, between 50 to 79, they are in the yellow zone. What yellow zone means that the asthma is not well controlled. However, if it is less than 50% of their best, that means that they are in the danger zone. Their asthma is not well controlled, and they should see the doctor as soon as they can. Thank you very much.
Let us have Peculiar talk to us of what we do in the center briefly for 3-5 minutes. Our online center here. Is she here?
Yes.
Yes.
Hello. Let's put our hands together.
Thank you very much, sir. Good morning, sirs and ma'ams. Good morning, everyone. My name is Peculiar, and I'm the respiratory therapist at the Asthma and Chest Care Foundation. I'd like to thank the professors, the doctors, and the entire organizing team for this opportunity. I am also thanking everyone for being here today. I'm privileged to be here today to share briefly about the Asthma and Chest Care Foundation. The Asthma and Chest Care Foundation is a registered charity committed to a healthy lung in a wholesome body through education, training advocacy, training research, and patient care. At the Asthma and Chest Care Foundation, we also render services such as getting information on lung health, performing lung function tests and ECG, counseling, chest care clinics, trainings and workshops, public enlightenment, and celebration for World Lung Days and the World Asthma Day, like we are having one currently. In addition to that, we give full doctor's reports and counseling after lung function tests. All this are what we do at the Asthma and Chest Care Foundation at an affordable price, of course. And we are currently located at the Sutu Spokesman Communication Ministries, Ife-Ibadan Expressway, Osun State, Nigeria. And I'd like to also let you know that you can kindly reach us via emails or call us at our number. The email is accf@chestcarefoundation.org, and you can call us at 081-2684-3300. I also like to leave with us that you should remember that you can be free of chest diseases. Thank you very much for listening.
Thank you so much. All right.
Thank you very much, Sister Peculiar. This question says, can MAT therapy be prescribed across all ages, considering limited variety of inhaled corticosteroid and cost of purchasing SABA and inhaled corticosteroids separately? I think this question has been answered. The cost, what we are saying is that single maintenance therapy, in as much as possible in patient that is firstly diagnosed, it's better to explain to them that this single inhaler that we are giving you, we can use it to control the inflammation. We can also use it to relieve the bronchospastic effect. That is what we call MAT therapy, single maintenance therapy in a single inhaler, which overall I think will even be more cost effective. The patient let me give an example. If a patient is buying inhaled corticosteroid, which is not singly available, let's say he's buying Seretide. Seretide now is like 22,000. It has come down. It used to be 45,000 during that crisis, or 50,000. And you also have to buy Ventolin that is like 9,000 or 7,000. That's like 30,000. Because I'm prescribing it separately. But if I'm prescribing I'm not, as we said, I have no disclosure, I have no shares in either of those companies. So if I'm prescribing a formoterol containing ICS, formoterol means that's the other LABA, other long-acting that can be used to relieve things. I think it costs like 16,000 or 14,000 or 16,000. So which one is cheaper? 16,000 or 30,000? 16,000 is cheaper, and the fact that you are only carrying one single inhaler, and I think it can be prescribed across all ages. Thank you.
Thank you, ma, for that response. Said, please, is the formoterol same as salmeterol? Well, just like that, we rightly said, both of them are LABA, long-acting beta-2 agonists, but one acts faster than the other. So formoterol acts faster, which is what the added advantage it has, that it can be used also as a reliever therapy. Yes, sir.
All right. Tell us a little bit about the asthma action plan.
Okay, sir. Thank you, sir, for the question. Now, in the management of asthma, we are going towards, the phase of partnership between the physician and the patient. That means it's not just dump management of patient. Go and use this, go and use that. It must be in conjunction. So asthma action plan is a written, well-documented plan that is often done in conjunction between the managing physician and the patient. And the essence of it is that it helps with individualized care for that patient. So the patient is a stakeholder. They know what their asthma is all about. So like a paper, you have the patient's name, you have the doctor's name, the patient's contact is there, what they are using, the inhaler they are using. So it helps them to have an idea of their daily medications. What they use on a day-to-day is documented in that sheet, how they should use it, the dose they are taking. So they have a good knowledge of what they are using. And also in that management plan, there's something that looks like a color coding which also incorporates what was just demonstrated for us, that is the peak flow reading. So it shows it, the red, the green, the yellow, which is the alert zone, and the danger, which is the red. So then the patient knows what it means. And apart from that, it also documents what the patient should do should there be a flare-up or an exacerbation of their symptoms. So a patient who is using just one puff in the morning, one puff in the evening, so it is documented. Should you be on the alert zone, quadruple your inhaler, so they know what to do before problem arises. And then also in that action plan, you also tell them what to do if they have a severe exacerbation of their asthma. That is, take for instance, patient is far away, transportation is a problem, and the patient finds him or herself on the red zone. They know at this point, I can take some oral medication, prednisone, which Prof mentioned earlier on, that is only used for a short duration. So the patient is well educated of what to do. And then in case of emergency, they have lines that they can call. So it's an all-encompassing plan, that helps the patient to take control of their asthma. Thank you, sir.
Thank you, sir. Please answer this for 1 second.
Please, can inhaler be used as prophylaxis for asthma attack? If yes, how can addition to inhaler be managed? Okay, I'll start from the second question. Do people get addicted to inhaler? In the real science, when we talk of science of addiction, not really. But if the person is just using Ventolin inhaler, what we have talked about over and over, if it's just salbutamol inhaler, there is what we call tolerance to it. When you use it every time, it won't work as much as it's supposed to work. So it means that the patient will have to be using more to get the same effect. So that is one of the reasons why Ventolin inhaler or tablet is not really the preferred choice. So what we use as prophylaxis, maybe this should be clear, that the maintenance therapy we are talking about, the controller therapy about, if it is used the way it should be used, there will be really little or no need to be using reliever therapy. Considering all other confounding factors, you avoid triggers, you know what to do, and things like that. So if you use your therapy, what we use to control the disease, what will control the inflammation, you use it morning and night, the need for trying to use a reliever would be drastically reduced. So there is no real addition to that when it comes to using inhaler. Once a patient is asthmatic, we confirm he's asthmatic. The patient has to use inhaler morning and night. Maybe depending on what is inside, maybe once a day. But patient has to use inhaler regularly to keep the inflammation under control. So it's not that the patient is getting addicted to it. The patient has to use the inhaler regularly. Thank you.
And addiction is something you can't control. And in asthma, we'll talk of asthma control. So anybody who's using inhaler is in control. Anybody who is addicted is not in control. Now,
thank you. Let's put our hands together for our erudite professors. We appreciate you, sir. I will just read this goodwill message from Dr. Bola Dale Abiodun, Deputy Director, Health Planning, Ministry of Health, Osun State. I wish to appreciate Prof. and his wonderful team. My comment is on early diagnosis, and it has been addressed. So I wish to congratulate you for all that you are doing, and I pray that everything will be successful. Let's put our hands together for Dr. Bola Dale Abiodun. We also want to recognize Professor Victor Okore online. Thank you. And all the many other people that we cannot mention your name one after the other. Thank you for being a part of us. And we believe that anytime we call you on you again, you'll be willing to participate. I hand over to...
Yeah, thank you so much. So many people online. Now, before I give the concluding statement, maybe we'll have Reverend Mr. Erhabor to say one or two words to asthmatics, encouraging words to asthmatics around the world watching us.
We want to thank the Professor Erhabor and Professor Okweju and Dr. Mrs. Kehinde, who are the team members and who has contributed greatly to today's success. To the asthmatics, I want to advise the asthmatics to believe that they can be healed and God can help them. And also to try as much as possible to be in connection with their doctors. Probably there are some centers without doctors, with their nurses, so that they will be able to constantly be reviewed and be helped. I also want to advise them to try and study what they react to. That's the triggers. If they are able to know what they react to, it will help them a great deal to control their asthma. Even if they go to somewhere else, they will know what to avoid wherever they go. And if they can find out what their triggers are, it will be, to me, I say it's like 50% victory for them. Because some people, when they know what they react to, like pollen, maybe field, when they caught field, they can avoid it anywhere they go. And when they see where it is one of the prevailing things, they can move to another sector of that particular environment they have gone to. And people like that will not bother to go and live in a house that there's field everywhere. They rather go and maybe tile their floor and other things. And also, if you react to dust, you know it's when the dust from the rug or whatever. You won't live in a house when you go and rug everywhere. You know, we see rugging as a prestigious living in the past. But now, if you see that is what you react to after your study, you'll be able to avoid such things and tile the floor, which is equally very good and beautiful. So I want to advise every asthmatic that you can overcome your asthma by taking some responsibility by yourself, and also don't take things for granted. Always be in contact with your caregiver so that you can always be exchanging views, and they can also help you to diagnose any problem on time. And with this and some other things you have been told today, I know you can overcome your asthma. I have a cousin who used to have asthma in the past, you know, and At one time, he bought some of this metro or whatever, and that's one, because you don't use it frequently, occasion. Maybe once you take it once a day, or for a long time, you may not need it. I think maybe I got the drug right. There was one time, there is a particular one that once you use it, you may wait for quite some time before you need it again. Today, she's free of asthma. So it doesn't mean because you have asthma, then you will have it for life. If you take care of it and you study it, and sometimes too, some psychological problem can give you asthma. Some people, if they have a lot of pressure, maybe home pressure and some other pressures, as people react psychologically to a lot of things. Some people, asthma may be their only reaction. But as you get psychotherapy, as you get over some of those problems, you can also see that you are overcoming your asthma reactions. They have said so much today. I know you can have victory over your asthma. God will help you. And be prayerful too. God heals. Thank you very much.
Thank you so much. Let's give her a clap. We want to thank, I will give a summary now. We've been here now for 2 hours. I want to thank the whole team. We wanted to start at 10 exactly. We started at 10 exactly. And we have been here for over 2 hours. So we thank everyone. We want to thank businessman Ayokule for his help. You want to ask a question? Okay, all right, okay. Oh, all right, okay, all right. Give me, okay. Or observation, okay.
Thank you very much, sir, for the seminar and for all your efforts. The seminar says bridging the gap between knowledge and practice. I've had enough knowledge today. Many names. I think I have my headache a little bit. But in the place of practice, to Dr. Dazenia government, where is the place of government in asthma management? When we talk about asthma, it seems it's for urban people. We have situations that I lost 2 people from asthma attack. Don't they have asthma in the rural areas? What is government doing? If not for foundations like this that Prof has set up, that has helped a lot of people. How many people know that it's asthma they have? And then they will put some concoction, drink this, drink that, and before you know it, the person is gone. Where is the place of government? Secondly, is there funding to support people in management of asthma? I think if this don't exist, it's that time we make a call on government to be more. I don't see why we can't have asthma or departments in health centers, because it's mostly with children and a lot of people. So I don't know, where's the place of government in the management of asthma and in the help of in the bit to help a lot of patients?
I think you have answered the question.
No,
because you have, all right, let him just add. You have both told us the thing that government has not been doing well. You can just amplify it for a short time.
Well, thank you very much, sir. My amiable businessman. First, I would like to disclose I'm not with government. I'm the Secretary General, Nigerian Thoracic Society. It's a non-profit organization of doctors and other healthcare professionals who actually focuses in diseases of the what? Lungs. So, but through our society, we engage government. That was what I said earlier on. Okay, so that is that, and we are indeed engaging with the government. Now, in the rural center, well, number one, you talk about people mixing concussions. Well, there is not much, well, people really, yeah, we need to keep advocating and keep educating people. That's the one thing I would say. Just last Monday, I was in my clinic, and one of my patients that actually came for follow-up for asthma. Should I tell you what her occupation is? I asked her, what's the occupation? I'll say it in Yoruba. She said, Elewe Omo. I hope you know what that means. Oh, she actually does herbal drugs and sells. That's what she does. But she came to clinic. She's on follow-up for asthma. And usually her asthma is well controlled. So I asked her, is there no drug amongst these your Elewe Omo things that you can use for your asthma? She said, doctor, please let's leave that. I've come here to take care of myself. Okay, so what am I trying to say? We need to educate our people. That is just it. Education. That's what we need to do in that regard. And indeed, I agree with you. A lot of people in our rural rural communities indeed have asthma. Honestly, on a sad note, that very Monday night, one of my neighbors came to me that, one of our sister was brought from Iwo yesterday. She was sick and that she's not breathing well. I should come and look at her. I said, why would you come and call me in my house to look at somebody who is not breathing well? I think what you need to do is to go to the hospital. But as a neighbor, as a friendly neighbor, it would be unfair if I refuse to come out. So of course I got up, went to the. By the time I saw the patient, she was wheezing loudly. I listened to her. Does she have asthma? They were like, many years ago she had asthma, but the asthma has gone. I said, obviously this asthma has not gone. Please, let's go to the hospital. Honestly, on a very sad note, we lost this patient in the hospital because the asthma was, apparently she had been breathless for quite a long time. In fact, when I saw her, obviously I counted her respiratory rate, I counted well over 40. Respiratory muscle fatigue, or she was so, eventually she died. Okay, and you see, so the importance of this is that truly there is asthma even in those rural settings too. But our people need to be educated, and we need to keep advocating and keep enlightening people. And these are part of things we must going to do with government, and which is why I also appreciate the Asthma and Chest Care Foundation for this, because things like this actually goes far too. Okay, thank God for internet now. I can confirm to you that, there are people in Iwo who are actually listening to this, okay, because of internet. So we must keep doing things like this to actually educate our government. Indeed cannot do everything, okay? So I would like to rest my case now. Thank you very much.
All right, before I make a conclusion, I don't know if Bukola wants to say one word. You want to say one word to the pediatric world, because we have a lot of people watching.
I want to say to people listening and to everyone that we're having increasing cases of childhood asthma. We should watch out, and we should not self-medicate, but rather children should be taken to the hospital when they have these symptoms. Thank you, sir, and everyone.
Let's clap for everyone. Now, my take-home word is this. We said that asthma death is preventable. Don't forget that. Then the second thing we said, which is very, very important, is that asthma is not diagnosed subjectively, but there's an objective management of asthma, both in the diagnosis and in the treatment. Again, we say that asthma is a combination of the gene and the environment. And it is not sacrosanct that if you are genetically predisposed, you would also have asthma. There are many situations and circumstances about asthma. We said that, we didn't say that, pregnancy can either quiet it, increase it, or reduce it. They used to say a rule of third. For pediatric asthma, people say that you can outgrow it, but I've met many pediatricians who say you don't outgrow it, but that it remains quiescent and it can come out. In fact, the body of evidence doesn't show that asthma can be cured. It can go silent when there are no trigger factors. We also tell asthmatics to always go categorize their own asthma and know what it is. We say that in asthma, we do not think about cure, we think about control. Not partial control, but full control. And we want you, as much as possible, to use a drug that combines both taking care of the inflammation and a short booster of relief. That the best therapy is what they call the primary therapy. The alternate therapy, although good, you need an additional inhaler to make it complete. When it comes to acute severe asthma, that is a different bottle of fish entirely. Now, when you notice, and those watching us, I wanted us to show the number of people online so you can see the people there. Now, when you have asthma, there are things you must know that your asthma is not getting controlled. One, when you need more additional inhaler for the same level of control. When you are waking up more nights because of your asthma and more days in the night you are not sleeping, that is also bad. Again, when as you find out that even when you take additional therapy, your asthma is not controlled and your symptoms are getting worsened. If your peak flow meter is dipping down, that is rather being controlled. In asthma disease, we don't talk about normal peak flow, we talk about best peak flow meter. That is your peak flow when you have no attack. It's on that basis we use it to calibrate your asthma. I would advise you quickly follow your action plan, which is given to you by a doctor, and come straight to the hospital. That is an acute attack. Don't allow the wheezing to continue. When the wheezing continues for a very long time, as medical students you will know, when a person has an acute attack, he has hypoxemia reduced and he has hypocapnia because the carbon dioxide, because of that diffusion capacity. But when he gets on, keep on getting bad, he now have hypoxemia and pneumocapnia. And when it's now very severe, he has hypoxemia and hypercapnia. In your multiple choice, if they say acute severe asthma, what does it cause? It causes hypoxemia and hypocapnia. But it's when it's getting to status asthmaticus, or we don't use status acute severe asthma, it causes hypoxemia and hypercapnia. When we manage asthma, we suggest 3 simple things for the acute management. Years ago, when I was teaching medical students, I said SOS. But what we say, nebulize beta-2 agonist, nebulize anticholinergic, oxygen, and then steroid. That oxygen is a moderate dose, not a high dose. And then when the patient is not able to be controlled by that, we can have additional therapy. Nebulizers are important because they give a high dose of the drug straight to the airways. But there's a thing we call spacer device. And pediatricians have different devices on it. They use bottle. This is, this spacer device is, maybe she can even demonstrate it for us briefly. Just demonstrate for us briefly, and then they can talk about it. Where's my other microphone? Just give her to demonstrate it for us what it does. Mm-hmm.
So this is one of the tools being used in asthma. We call it spacer device or a volumatic. So it can be used to administer the inhaler. Well, especially in acute phase or for patients who find it difficult to have some form of coordination, especially in the elderly, in terms of action coordination mechanism when they are using their inhaler. So what it does is that the inhaler, so the space here is where the inhaler is being fixed, and then the other hand is where the patient puts into their mouth and wrap their mouth around. So once you fix the inhaler, you can now puff it, and it helps to generate, the smaller molecules in such that it helps to deliver those smaller molecules down to in the air. So you have a lot of the inhaler being delivered into the air rather than when you are just doing it and a lot of is being wasted. So you can use it out of the hospital where you do not have access to nebulizer. So while you are still trying to get the patient into the hospital, or patient can even have it in their homes. So because at that point they find it difficult to breathe, having to pop their inhaler may be difficult. So you can put their inhaler and then it helps to generate.
Yeah, it's called a spacer device. This is volumatic from GSK, but a spacer device, I can adapt it. The truth about it is that no matter how much you use your ordinary inhaler, the number that comes into the airways is very small, and it's not enough to control it. But volumatic takes the bigger droplets, it puts it down, and allow the smaller aerosol to go straight into the airways and help. Now, nebulizers are now cheap. Those, I think, was 25,000. I don't know what it is now.
90,000.
But you can actually have the nebulizer in your house. and then if you have with a solution, and there are pocket ones, there are handy ones, and there are battery used, the other ones, some has to use with oxygen and so on. So please don't stay at home. When your child has asthma, please contact the healthcare practitioner. As of today, there are no herbal remedies that I know can control asthma. And please don't let anybody tell you that there's a herbal remedy to control asthma. And you must see your doctors who will do an objective management of your asthma. Like every other disease in this world, you have to maintain a good body health. Exercise when you can, and if you can, and daily, have good nutrition, sleep well, and worry less. Your productive capability is really enhanced when you take care of the engine of production yourself. Don't wait for disease to raise the alarm. Check yourself often and follow the simple rules. I was speaking on Wednesday to a group of doctors, and I said there are 3 simple things all over the world we know give health: nutrition, exercise, and sleep. If you do these 3 things well, you will send the doctors far away. So sleep well, have good nutrition, and then exercise. I also know that a peaceful mind has a way of giving a long health. For me, the way I get this peaceful mind is my relationship with God. And I would advise you to look for those peaceful mind. And don't allow anything worry you or bring you down. Thank you so much for having been with us today. We want to thank the CMD of Baesa, acting CMD of Niger Teaching Hospital, who gave us a little donation. We want to thank our CMD who has promised, and I know he will execute. And we want to thank 1 or 2 or 3 of my friends who has given us some donation to make it possible. Everything we do here is all our own donation. We don't have anybody coming on. Like before, a lot of drug companies will sponsor it. There's no drug company sponsoring what you are seeing today. It is all we all generated from our own, including your minerals and your egg roll. So everything was. So I will thank you so much. The centers are available. We have things to go, and there is a book on asthma. You can always get it. Please can Peculiar come and stand by the stand. If you need it, she can also tell you what to do it. So thank you so much for being here. And I don't know if we could call Ms. Ladipo to pray for us, a short prayer, because it's not a really, pray for women are used to making very long prayer. If she can give us a short prayer as we conclude.
Thank you very much. It has been a very insightful session. And can we just pray? Father, Lord, we want to thank you for today. Lord, we thank you for this foundation. We thank you for the president. Father, Lord, we thank you for all the team members. Lord, we thank you for such insightful and revealing session. Lord, I pray, oh Lord, that, Lord, you continually bless their efforts in the name of Jesus. And that, Lord, even for us all that have come, Father, Lord, to be educated, I pray that we'll be able to translate this information even as much as possible to those that will need it, and we'll be able to save life through this in the name of Jesus. As many that will be traveling, as many that will be leaving this destination from one place or the other, we ask for travel mercies, and that, Lord, your presence will never depart from us. Thank you, Lord, because this foundation will continually be strengthened in the name of Jesus.
Thank you, Lord, for in Jesus' name we have prayed. Thank you.
Can we all clap today? I want to thank the technical crew of the Spokesman Communication Ministry. This week has been so loaded. On Wednesday, we had a sleep meeting. And yesterday, we had a leadership meeting. And today, we have an asthma meeting. And Sunday, we're having 4 meetings. So I want to thank them for their labor. And at this rate, I think they deserve about two of your egg roll each. May the Lord bless you. Have a safe journey back. Can we have a group photograph, please? A group photograph. Yeah, thank you very much. Thank you. Can we have a group photograph? Oh, yeah.